Welcome back to the Deep Dive. Today, we are strapping in for a really high-fidelity look at a specific surgical technique. We're basically putting on our scrub cap, stepping into the OR, and doing a deep, meticulous dive into the use of the central quadriceps free tendon graft, which is called QTB, for anterior cruciate ligament, or ACL, reconstruction.
This is truly where the rubber meets the road, surgically speaking, where technique meets material science. Our source material today is it's intensely focused, pulled straight from deep surgical notes, specifically Chapter 49, drawing heavily on the work by pioneers like Sloan and Zerjanis.
So what's our mission today?
Our mission is critical. It's not just to walk through the steps, but to really extract the why, the precise technical rationale, the procedural gotchas, and what really positions the QTB as a top-tier alternative to, say, a bone-patellar tendon-bone or a hamstring graft.
Exactly. And when you look at ACL reconstruction as one of the most common sports surgeries in the world, yet the debate over the perfect graft, it never really settles, does it?
It never does.
We're always trying to balance everything. High tensile strength, minimal donocyte morbidity, good cosmesis, predictable healing. It's kind of the ultimate surgical dilemma.
It is, and you see the surgical pendulum just constantly swinging. The beauty of the QTB is that its recent, explosion in popularity is actually more of a renaissance. It feels cutting edge, but surgeons like Fulkerson and Langeland were proving its viability way back in 1995.
So this is really a decades-old concept that's just now being enabled by modern, minimally invasive instruments?
That's it, exactly. And the sources argue the resurgence is justified because the QTB just has better material properties. I mean, Sloan and his colleagues called it an ideal option back in 2015.
Based on its anatomy, histology, and biomechanics.
Right. It's fundamentally thicker, it's stronger, and it has a higher density of collagen fibers than, say, a hamstring tendon. Plus, and this is a big one, unlike the BTB, we're not harvesting bone plugs.
Which cuts down hugely on that debilitating anterior knee pain that can plague athletes for years.
Hugely. And the QTB is just so versatile, it integrates almost seamlessly with any modern fixation method we want to use, including advanced stuff like the tightrope RT, which I'm sure we'll get into.
And that push towards smaller incisions, driven by those specialized instruments you mentioned, that seems to be the key that's making this technique viable for everyone, not just a few specialists.
Absolutely. It takes the guesswork out. It turns the harvest from this kind of artistic freehand incision into a precise calculation. All right, let's unpack this whole thing, starting where it should, with the patient in the clinic, long before they even see an OR.
Agreed. Let's start with Section 1, preoperative planning and assessment. So when we talk about this decision matrix, we're looking way past the tear on the MRI. The material really emphasizes that the graft choice hinges on the patient's age or avocations. Are they a professional athlete or a construction worker who needs to climb ladders?
This is where we really earn our paycheck, connecting their life goals to the best hardware. I mean, think about the difference between a 16-year-old competitive skier and a 55-year-old manual laborer.
Completely different priorities.
Totally. The skier demands maximum rotational stability and the absolute minimum setback to their quad function. The laborer, his priority is just simple stability and getting back to carrying heavy loads as fast as possible. For that skier, minimizing anterior knee pain, a huge BTB concern, and maximizing quad strength retention makes the QTB incredibly compelling.
I get the patient-specific variables, but the sources also stress this non-negotiable surgical foundation, right? The knee has to be cool and quiet.
That is the absolute rule of the road. You must obtain full symmetric range of motion before you operate. Trying to operate on a hot, swollen, stiff knee, what we call an effusion. It's just the quickest way to guarantee a long, painful post-op course filled with arthropibrosis. It's like trying to rebuild a house during a hurricane. You don't do it.
So that pre-op physical therapy isn't just about strength. It's mandatory for controlling the swelling and, more importantly, getting that quad musculature firing correctly before we even think about touching it with a knife.
Precisely. If that quad isn't firing, the patient is compensating. And when you take even a partial thickness graft, you're temporarily knocking out that extensor mechanism. If they start from a weak base, their rehab is going to be miserable. We're using a piece of their main engine. We need that engine tuned up before we start tinkering.
Okay, now let's get to the imaging. This is where the modern MRI planning seems absolutely essential for checking that quadriceps tendon thickness.
Oh, it's critical. We need to know the density of the material we're working with. And the technical detail here is extremely specific. The measurement is taken at the mid-sagittal point of maximal thickness,
which is standardized at exactly 3 centimeters proximal to the proximal pole of the patella.
Right, that 3 centimeter mark is our reference point. It minimizes error.
And why that specific spot, 3 centimeters up?
That's typically where you find the most consistent, substantial part of the central tendon before it starts to fan out or thin out too much. It just gives us a really reliable baseline thickness to plan our cut.
So we have the measurement. What's the threshold? What's the magic number that tells us we're doing a partial thickness harvest versus a full thickness one?
If the pre-op MRI shows the total tendon thickness is less than 6 millimeters, that's our hard cutoff. If it's 6 millimeters or less, we just plan for a full thickness harvest right from the start to make sure we get a robust graft. If it's over 6, we stick with the standard 7 millimeter deep partial thickness cut.
That 6 millimeter threshold is a really valuable clinical pearl. But what about the impact? I mean, does taking the full thickness compromise the patient long term?
And here's the crucial insight from the outcome studies. Functionally, there is no significant difference observed in long-term quad strength or stability between patients who got a partial thickness versus a full thickness harvest.
That's a huge relief, especially for a resident planning their first few cases. It basically confirms that even if we have to take the full thickness, we're not sacrificing the final outcome.
Exactly. It just means our closure and our post-op management become a bit more attentive. The quad tendon is a vast redundant tissue. Its thickness is rarely inadequate, which is one of the reasons it's gained so much favor. Universal applicability. So once that planning is done, we move to the table.
All right, section 2. Surgical setup and initial visualization. Let's talk positioning. General anesthesia, check. Tourniquet on the operative thigh, check. But the technical setup seems key for the harvest itself.
Positioning is everything here, you're right. If the leg is just dangling or not supported right, the harvest gets way harder than it needs to be. So the operative leg is placed in a circumferential leg holder, which lets the knee just rest naturally at exactly 90 degrees of flexion.
And why is that 90-degree position so crucial for this specific graft?
It does two things. First, it brings the top of the patella forward and down a bit, which straightens out and exposes the quad tendon. Second, and this is the most important part, it maximally relaxes the quad muscle group. When the quad is relaxed, the tendon is supple, and that makes our precise 7 millimeter depth cut so much easier and more predictable. Trying to cut a tight, tensioned tendon, you're just asking for trouble.
And while that's happening, the other leg is secured in a well-padded lithotomy holder. Standard prep, drape, S-march bandage, all foundational.
But that 90-degree rest position is really the secret sauce for an easy QTB harvest.
It absolutely is. Now, the workflow question, the timing. Do we harvest the graft before or after the diagnostic scope?
The preferred sequence, according to the source, is to start with the graft harvest, especially if everything history, imaging, exam under anesthesia points to a straightforward ACL rupture. Get your currency first. I agree with that preference 100%. Get your graft, confirm its size and quality, then go do the joint work. But if you deviate, let's say you do the scope first, then you run smack into the critical fluid management issue.
Yes. The material flags this as a major procedural gotcha. If you harvest after the scope, you have to drain every last drop of that arthroscopic fluid out of the knee.
It is non-negotiable. If you don't, you dramatically raise the risk. When that joint is distended, the fluid creates hydraulic pressure that pushes up on the undersurface of the quad tendon.
And when we start our controlled partial thickness cut,
that pressure makes it incredibly easy to accidentally make a full thickness perforation. You're trying to make a precise cut on the front while the back is being pressurized like a car tire.
So it's the surgical equivalent of trying to slice a piece of parchment paper that's floating on top of a water balloon. Any little overpenetration with a knife, pop, you're blown through the back wall.
That analogy is perfect. And when that happens, you risk losing your graft into the joint space. It's a mess. You want the tendon relaxed and flat, not bulging. This is one of those little nuances that separates the experienced surgeon from the novice.
That makes the sequencing rationale crystal clear. If you have to scope first, take the 5 minutes, drop the leg, and squeeze every drop of that fluid out before you start the harvest.
Time well spent. Okay, so the setup is pristine. Let's get into the harvest technique itself.
Section 3, the detailed central quadriceps tendon harvest technique. We start with landmarking. Knee flex to 90. We mark the proximal pole of the patella, the border of the VMO, and the medial and lateral patellar borders.
Meticulous marking is key. That VMO border is critical because we want to stay dead center. We don't want to wander off into the muscle belly. We're aiming for that tough, central, fibrous part of the tendon.
And the incision is small, which is the cosmetic advantage. Just a 1.5 to 2 centimeter mark going proximally from the patella. But here's the critical visualization tip. Inject local with epi, and then excise a wide ellipse of subcutaneous tissue and fat.
That wide ellipse is absolutely non-negotiable if you want to see what you're doing through that small keyhole. If you leave all that spongy fat in there, it just collapses into the wound and you can't see a thing. It's like trying to thread a needle while wearing boxing gloves. You've got to excise that fat to give yourself clean vertical walls right down to the peritoneum.
Right. Once that's cleared, we move to figuring out the proximal extent. This is where that transillumination technique comes in, which I find is truly ingenious. It's referenced in figure 49.4.
It really is. It's turning the invisible into the visible. You take the arthroscope fluid off and you slide it into the wound right up under the tendon until it stops at the myotendinous junction.
Then you just rotate the light cord to shine the light up through the skin on the thigh.
Exactly. And the light source creates this glow on the skin. You mark that spot of maximal glow. Now, why do this? Because you can take a ruler and measure from that spot down to the patella and get a very accurate estimate of your potential graft length before you ever make a cut.
That's brilliant. It avoids that nightmare scenario of starting the cut and then realizing the patient's muscle belly starts way lower than you thought.
Exactly right. It tells you if you can stop at the targeted 7 centimeters or if you need to go a bit longer. Okay, we've mapped it. Let's talk about the knives.
The longitudinal cut, which is in figure 49.5, uses the specialized Arthrex quadriceps tendon harvest knife.
This little tool standardizes the whole process. For most patients, we're setting it to a blade width of 10 millimeters. That's a good standard diameter for an ACL graft, and a fixed depth of 7 millimeters.
Let's talk about that 7 millimeter depth. Why is that the magic number?
7 millimeters is the sweet spot. In tendons thicker than 6 millimeters, it ensures a partial thickness harvest while leaving a really substantial, healthy remnant of tendon behind. If you go shallower, say 5 millimeters, you risk getting a graft that's too thin. If you go deeper, you significantly increase the risk of violating that posterior capsule. So it's all about standardization. 10 wide, 7 deep.
We press the knife firmly onto the tendon and then advance it proximally toward that transillumination mark we made.
And this brings up a great procedural nuance, the direction of the cut. The preferred method is the retrograde push motion.
You know, as a resident, my first instinct would be that an antegrade pull would be easier, using gravity and tension. Why the preference for the retrograde push?
In practice, we've just found the retrograde push to be more predictable and controllable. When you push, you maintain a consistent downward force and a better line. The pull technique tends to wander or skip, especially through dense tissue. You can get a ragged edge, which you don't want. It's all about consistency.
Noted. Push, don't pull. Once we're at the proximal mark, we use a 15 blade to carry those longitudinal incisions distally down to the top of the patella.
And here's a critical little step. Tapering the distal end slightly. You have to account for the fact that once you put the whip stitches in, that graft is going to swell by about a ½ millimeter, maybe a full millimeter. If you don't taper it, you'll fight like crazy trying to pass it through the tunnels.
After connecting the two cuts, we dissect the tendon off the patella. And this is where that second major warning comes in.
You have to be surgically aware here. Look closely. There's a thin layer of fat that separates the quad tendon from the underlying joint capsule. You must stay superficial to that fat layer. If you violate it, you've just created a hole into the joint, which you don't want in a partial thickness harvest. Stay high.
Then we carry that dissection up proximally with Metzenbaum scissors, using an Alice clamp on the tendon end for control.
That control is essential. And this leads to another signature of this technique, the early whip stitch. Once you've elevated about 3 centimeters of tendon, you use a looped suture to whip stitch the end, starting about 2 centimeters from the patellar end.
4 throws, lock the last one, leave the needle on. So this stitch basically gives the surgeon a reliable, non-crushing handle for the final stripping part.
Precisely. If you just pull on it with the clamp, you can tear the graft. The whip stitch distributes that tension evenly. Then comes the final move, referencing figure 49.6, the Arthrex tendon stripper cutter.
We slide the stripper proximally until we hit our desired length, using the ruler right on the shaft for measurement, and then the cutter is deployed to finish the harvest.
And the clinical target is 7 centimeters. 7 centimeters of dense 10 millimeter wide tendon is generally more than enough for an anatomic ACL reconstruction in most patients. That's shown in figure 49.7.
Post-harvest management.
Yeah.
We put the scope back in, fluid off, and evaluate the harvest site. What are we specifically looking for?
We're looking for that full thickness rent we talked about, the accidental perforation. If we find one, we immediately close it with some interrupted zero-vicryl sutures to restore the integrity of the extensor mechanism. Then we place a strip of gel foam in the harvest site.
And the gel foam is mainly for hemostasis to prevent a hematoma.
Correct. It also acts as a kind of temporary biological scaffold. This step really minimizes that donor site pain and swelling, which is critical for getting the quad firing again quickly in rehab. It's that attention to detail that delivers the low morbidity that QTB promises.
Okay. Section 4. Graft preparation and tunnel drilling. We have our pristine 7-centimeter graft. Now comes what you call the whip stitch symphony. This is arguably the most fiddly part of the whole operation.
It is detail-oriented, no question, but it's essential because this is what determines how securely the graft transmits load to the hardware. We use a looped suture for the proximal side fourth rows, starting 2 centimeters in, locking the last stitch.
And we assign the ends. The smaller diameter end, usually the one we took off the patella, is designated for the femoral side.
That's standard practice. That end is often a bit smaller, so it passes more smoothly through the femoral socket, minimizes damage during shuttling.
Now let's detail the femoral fixation prep using the tightrope RT. This looks complex.
It is, but there's a reason for it. The goal is to integrate the device so the load is circumferential, not just on a single point. You take the needle from your first whip stitch, pass it through the loop of the tightrope, and then pass it back through the center of the graft, exiting about 5 millimeters from the end.
Then 3 more throws moving away from the end. Cut the loop and tie the tails around the graft.
And that sequence creates an incredibly robust connection. We're essentially using that tightrope to suspend the graft high up on the femoral cortex. The complexity of that stitch ensures that when we tension it, the forces are spread evenly throughout the tendon. It converts a linear pull into a broad circumferential load.
That really clarifies the mechanical thinking behind that detailed stitching. The tibial side is a similar whip stitch process.
Correct. 4 throws, lock the last stitch. Once the graft is ready, we move to the tunnels, which have to be anatomically perfect after we've dealt with any other cartilage or meniscus issues.
And what are the key landmarks for tunnel placement?
Well, it depends on how old the injury is. In an acute setting, the ACL stumps, the remnants of the native ligament, they're our best friends. They literally show you where the original ligament inserted.
But what if it's a chronic injury and those stumps are gone?
Then we rely on the bone geometry. On the femur, you're looking for the intercondylar ridge and the bifurcate ridge to find the center of the native footprint. That's your target for the femoral tunnel.
For the femoral tunnel, the sources recommend using an accessory far medial portal.
Yes. That far medial portal gives you the best angle for an anatomic socket, especially for a single bundle recon. It lets you hit that 10 o'clock or 2 o'clock position perfectly.
And you have to view this with the scope in the anteromedial portal.
Absolutely. That gives you the bird's eye view of the femoral footprint. Lets you see that your guide pin is perfect. We drill those femoral sockets to 25 millimeters. That's a standard, reliable depth.
Okay, next is tibial tunnel precision. This is where roof impingement is the big boogeyman if you get it wrong.
Exactly. The tibial tunnel is marked in the center of the footprint, which is usually parallel to the anterior horn of the lateral meniscus. And here is the third major technical warning. The soft tissue suture bridge check. This is so often missed when people are rushing. The looped sutures from both tunnels, the femoral and the tibial, have to be grabbed at the same time and pulled out the accessory portal.
And what happens if you skip that simultaneous check?
If those sutures get snagged or cross over some soft tissue, like the fat pad, they create a soft tissue bridge. When you pull the graft through, that bridge can cause it to twist or hang up. Your fixation integrity is compromised before you've even tightened anything. You need a clean, direct line of pull.
That makes perfect sense. Once that's clear, the graft is passed into the femoral tunnel first, leaving about 5 millimeters of the tightrope cord out for final tightening, then into the tibial tunnel.
Right. We cycle the knee a few times, flexion, extension, with a little tension on the sutures to seat the graft and make sure it doesn't impinge anywhere. Then we lock it down, and the knee position here is critical.
Tibial fixation first. Sutures are tied over a post with the knee in full extension.
Full extension. That's the rule for QTB fixation. Unlike a hamstring, where some surgeons might tie it in slight flexion, the QTB protocol explicitly requires maximizing tension at terminal extension.
Why the strict requirement for full extension with QTB? Is it just that much stronger?
We need to ensure the strongest possible tension is there when the knee is fully straight. We're trying to mimic the native ACL, which is maximally taut in extension. If we tighten in flexion, we risk losing that crucial terminal extension stability.
And then the femoral side. Final tightrope tightening is also done with the knee in full extension.
Double confirmation. You want that femoral suspension locked down while the graft is maximally tensioned. Once it's secure, we'll do a Lachman and pivot shift test to confirm we've built a rock-solid construct.
Moving on to post-op. Since we've harvested part of the extensor mechanism, does that mean a completely different rehab protocol than, say, a hamstring graft?
The general principles are similar: protection, controlled motion, progressive loading. But because we've just put a defect in the quad tendon, the primary emphasis has to be aggressive work on achieving full, early motion and specifically regaining terminal extension immediately.
So terminal extension is the absolute gold standard for success.
It is. If a patient gets stiff there, it leads directly to arthropibrosis. We have to fight the knee's natural tendency to rest in slight flexion because the quad is sore. We need them working on passive extension and quad sets right away.
And what's a typical timeline for an isolated QTB ACL, assuming everything goes smoothly?
We're usually pretty aggressive. Weight bearing as tolerated once quad function returns, which is usually just days to a couple of weeks. Inline jogging can start around 3 months, assuming they hit their strength metrics, and then return to sport, generally between 7 and 9 months, but only after rigorous functional testing.
And looking at the strong clinical outcomes referenced in the sources, it really validates every single one of these technical steps we just went over. The precision is what delivers the results.
It really does. I mean, the QTB kind of resolves the biggest historical conflicts in ACL surgery. It gives you the structural robustness of a BTB, but without all the anterior knee pain. And it avoids the hamstring weakness issues. The key takeaway is simple. The outcomes hinge entirely on the precision of the harvest, the robustness of the prep, and that final fixation in full extension.
So to synthesize this incredibly technical deep dive, the central quadriceps tendon graft really emerges as a versatile, anatomically sound choice. Success depends on detailed pre-op planning, that MRI thickness check, and meticulous execution in the OR.
Right. We talked about the 3 pillars. First, superior visualization from that wide ellipse excision and the transillumination. Second, the consistency of that 10 by 7 millimeter cut using the retrograde push.
And third, that final fixation protocol, the complex whip stitching and the mandatory tightening of both ends in full extension to maximize that terminal stability.
And the data backs it up. Excellent long-term results, low donor site morbidity. It really positions the QTB as a superior alternative to the traditional BTB graft for a lot of athletes.
It's an approach that's just defined by precision. Okay, for our final thought for the learner, something for you to think about. We spent a lot of time today detailing the whip stitch symphony, that complex suturing required to integrate the soft tissue QTB into our current hardware.
We did. We rely heavily on that technique to load the graft uniformly and connect it reliably to things like the tightrope.
So the provocative thought is this: if we know the results are excellent and the morbidity is low, what future biomechanical or material science research would be necessary to push QTB fixation even further, to maybe eliminate the need for complex whip stitching entirely?
That's a great question. It's really asking us to think beyond our current hardware. I mean, imagine a world where you had some kind of biointegrated anchor or a sutureless matrix that could bond the tendon directly to the bone tunnel, achieving that same high tensile strength fixation without all that time spent meticulously stitching. What materials would we need to do that? That's the next frontier in soft tissue fixation.
Always pushing the envelope. That's a great challenge to end on. Thank you for walking us through this incredibly technical deep dive.
Always a pleasure. We'll see you in the next case.